on combined cyclical or sequential HRT, bleeding in progesterone-free period is very normal. Any unscheduled bleeding refers to the bleeding at other times. This is abnormal and should thoroughly investigated. Endometrial polyp. My second speaker is going to be elaborately talk on this. This is a wonderful picture on saline infusion sonography showing endometrial polyp and cervical polyp. Endometrial hyperplasia. We would be emphasizing more on this. It is an abnormal proliferation of endometrium. It accounts 5 to 10% of PMB. It occurs due to excessive estrogen stimulation. More than 3 mm in postmenopausal transvaginal ultrasounds. Endometrial thickness is significant and more than 5 mm for those on HRT. We will skip the classification. Endometrial carcinoma is the second most common gynecological cancer, is mainly adenocarcinoma arising from the lining of the uterus. It may be estrogen dependent tumor. It accounts for the 10% of postmenopausal bleeding. Out of all this, 90% of patients with endometrial CA will present with bleeding. So any PMB, we should be having back of mind that she may be having CA endometrium. Now coming to the approach of PMB management, history taking is very crucial. When was your last period? We want to rule out whether she is really in menopause or she is in perimenopause. When did the bleeding start? Where the precipitating factors such as trauma was there or not? What is the nature of bleeding? Whether it was temporary? How was the pattern, flow, duration? Whether it was postcoital or not? Quantity, how was the quantity? And what was the color? History of risk factor in C endometrium should be also evaluated. All patients with diabetes, hypertension, dyslipidemia, metabolic syndrome, obese, high BMI, late menopause, nulliparity, and use of unopposed estrogen should also be asked. Are there any associated symptoms such as pain, fever, and changes in bowel bladder function should also be asked. Is there a personal or family history of bleeding disorder or personal or family history of any malignant disorder should also be asked. Whether she is taking any medical history is also important. If she is taking any medication, we should ask for whether she is taking hypertensive medicine, diabetes, HRT, tamoxifen, and even some local ginseng preparation, herbal medication, that also contains estrogen. So we also should ask that whether she is taking anything. Is she having coital relation, HNPCC syndrome, hereditary non-polyposis colorectal cancer, women have markedly increased risk of C endometrial compared to women in general population. Any past surgical history, like if she had any leiomyoma in the past operated, ovarian tumor operated, whether she had breast surgery operated, anything we can ask for. When was your last smear done? Any cervical smear was positive or not, we want to emphasize on that. Coming to the clinical examination, general and systemic examination should be performed to look for the signs of systemic illness. It gives an indication to patient's general health and well-being, obesity, pallor, pulse, BP, weight loss, thyroid, whether she is hypo or hyperthyroid, she is cachexia fever. Any weight loss more than 5 to 10% in menopausal age should be warranted and should be treated, should be cautious about malignancy. Abdominal and pelvic examination, we all know. Speculum examination of cervix, I would emphasize that we should not forget our speculum examination in this TVS era. Sometimes we just forget to do speculum examination. We miss so many things in that. So this is forgotten art and should not be missed. Should be done in all the patients in our OPD. Whenever we find any abnormal discharge, abdominal mass, any suspicious lesion seen on the cervix, should be taken cervical smear or colposcopy should be done. This is colposcopy. Our aim of examination is to focus on determine the bleeding side, whether bleeding is coming from vagina, vulva, cervix, uterus, bladder or rectum. And to note any suspicious lesion, whether it is tumor, foreign body laceration, cervical polyp, senile atrophic vaginitis or ulceration from the ring pessary or even prolapse uterus and decubitus ulcer should be noted. Assess the size and contour and tenderness of the uterus per rectal examination to exclude the colorectal problems. Approach to PMB management. In general investigation, we will do all routine investigation. We all know CBC, coagulation studies, LFT, RFT, and tumor markers. Special investigation is the TVS is the gold standard. We all know it is the measurement of endometrial echo complex is very much in needed. We have to do it thoroughly. It should be measured properly. Any more than 4 to 5 millimeter on ultrasonography should be suspicious. If she is taking HRT, we can do 4 to 6 millimeter is fine. If she is on tamoxifen, 8 to 9 millimeter is fine. Otherwise, it should be sampled. This is ultrasound machine. Now endometrial sampling. We will do by 3 ways, whether it should be done office biopsy by PIPL, dilatation and curettage, and histro-guided biopsy. Office biopsy is a good when global and generalized disease is there. It gives a good result. But the limitation is we may miss 10% of failure rate are there because of missing the local cause or focal cause, and there may be a poor tissue yield, and in 10% it may fail because of cervical stenosis. Second is dilatation and curettage. Now it is no longer a first line therapy. Previously it was a first line therapy because the 10% of lesion can be missed. It was previously gold standard, but now hysteroscopy is the gold standard. So DNC is still good in poor low source setting. Histro-guided biopsy is considered the gold standard because it has many advantages. Histro prior to curettage is less likely to miss any lesions. It allows direct visualization and precise biopsy in case of focal and local lesion. It improves the detection rate of CA, and second most important is we can see and treat at the same time. Many benign lesions like endometrial polyp, fibroid, removal of foreign body can also be treated simultaneously, which is 50% in case such happens. So office hysteroscopy is very good, and even it can be done without anesthesia. This is office hysteroscopy and in-house patient hysteroscopy. Now coming to the MRI, it is expensive and not practical to screen in PMB, but only when we are suspecting C endometrium hai hi, then only we would want to know whether myometric invasion is there or not. Approach to PMB management is according to condition diagnosed after the underlying cause is detected. Endometrial sampling is done, and once it is coming atrophic, we will observe them. When it is coming benign hyperplasia, we will give them continuous or cyclical progesterone. We will resample their endometrium after 6 months, and consecutively every 6 months we will do till the 2 negative samples are coming negative. Whenever there is a proliferative hyperplasia, we will give them continuous or cyclical progesterone, and we will keep them in high-risk vigilance. Whenever there is a endometrial intraepithelial neoplasia, TH and BOSO is gold standard. And whenever there is a endometrial cancer, staging laparotomy with TH, BSO and pelvic lymphadenectomy is advised. This is treatment of CA cervix. We will not go in detail. Now prevention. How can we prevent it? I don't think we can prevent it, but we have to keep in mind whenever we are giving HRT in postmenopausal patient, we should be, those who have uterus should be always treated with good progesterone to prevent unopposed estrogen stimulation, which may lead to endometrial cancer. And in reproductive age, women who have chronic anovulation and such as PCO syndrome should also be treated with progesterone to avoid endometrial hyperplasia from unopposed estrogen. Thank you.
Thank you, Dr. Hina. Yes, postmenopausal bleeding is very alarming. Especially Indian women regard menopause as something that has to be attained, and once they've attained it, then they are very, very comfortable with themselves.
Yeah,
and then suddenly to start bleeding again makes everybody panic. That was a very good introduction to postmenopausal bleeding. All the causes have been described in detail and all the investigations. Thank you.
Thank you very much.
I also appreciate that you spoke about the thickness with tamoxifen. So that is very important. How many years into menopause? So 3 mm is after 5 years of post-menopause.
Yes.
Before 5 years is 4 to 5 mm. So based on whether you're on antihypertensives, whether you're on tamoxifen, so that history taking is very important
Very
for
important.
your cutoff for your lining.
Even in some of those patients who are asymptomatic, those who don't have PMB, but still when we are doing the TVS, there may be some thickness is there. So that we don't sample them, but we just keep them observation.
Yes, absolutely. Yeah. Thank you.